Now starting with the interactive session of panel discussion. Today we have Dr. Umair Javed, who will be the moderator for this session. Dr. Umair did his training from Sheikh Sayed Federal Postgraduate Medical Institute. He is EULAR certified and now working as a consultant rheumatologist in Indus Hospital. Sir, please kindly come on stage and moderate this session.
Thank you. Assalamu alaikum everyone. After lunch, I think everyone is dozing off a little bit. So a little bit more time. This is the last session of today's conference. I'm honored to moderate this session, and I want to congratulate Dr. Tafazli Haq, Dr. Aflaq to organize this session. And I want to invite our panelists on the stage. First of all, I want to invite Dr. Shakaib Qureshi. He is an American board certified rheumatologist. Sir, please come on the stage. Next is Dr. Mesam Afzal, Head of Department, Rheumatology Department, Gulab Devi Hospital. Our third panelist is Dr. Syed Ali Rukh Pirzada. He is Assistant Professor in Quaid Azam Medical College, Bahawalpur. And the fourth panelist is Dr. Ashraf Ali Khan. He is American board certified in infectious disease. Sir, please come on the stage. And Dr. Khalid Parvez Babar will be joining us online. He is an associate professor in University Medical and Dental College, Faisalabad. This is our first case. 23-year male student resident of Lahore admitted via OPD on December 2023 with complaint of worsening cough from past 2 weeks. This patient has left ear discharge which was present from past 8 months, and it was scanty yellowish in color associated with ear clogging and left ear hearing loss. Patient saw numerous ENT specialists for which antibiotics were prescribed, followed by brief improvement in the above mentioned symptoms. Hello. So the patient was having worsening cough from past 2 weeks. This was the presenting complaint. And in HOPA, patient was having left ear discharge from past 8 months, which was scanty and yellowish in color, associated with left ear hearing loss. Patient took numerous antibiotics during this course. Second complaint was joint pain, which was present from past 7 months, and it involved small and large joints bilaterally, involving MCPs mainly, associated with swelling, redness, and tenderness, with early morning stiffness of less than 30 minutes. The cough started from past 2 months with small amount of blood-tinged sputum and not associated with any constitutional symptoms, wheezing, or dyspnea. At this time, 2 months back, patient was again managed on lines of lower respiratory tract infection. Now, 2 weeks back, patient developed hemoptysis along with the cough, along with facial pain, which was localizing to the paranasal sinuses area, along with blurring of vision with watery discharge from eyes. He first presented in department in September 23. Available treatment options were discussed with them, but the family wasn't compliant. The patient visited rheumatologist and they started mycophenolate mofetil at the dose of 2 grams per day, along with prednisolone 40 mg per day. So what other key areas in HOPI should have been explored in context of above mentioned symptoms? Because in rheumatology we are facing autoimmune diseases and they don't usually present every time with the joint pains. Sometimes physicians find it difficult that what the disease is going on. Dr. Mesam, please, if you can.
Assalamu alaikum. This history, which is quite a chronic type of history, it all started with the ear discharge and then cough and hemoptysis and then inflammatory joint pain. From the history, obviously we know that something chronic going on. And then when we see such type of history, we think about, because the patient's infection is not resolving with the antibiotics, so we should think about other causes like vasculitis and tuberculosis and tumors and foreign bodies, etc. So because this history is directing us toward the vasculitis, from the rheumatology perspective. So obviously we need to explore a little bit more, ask the history of any nasal discharge, nasal bleed, any nasal crusting, ask about any mouth ulcers, and hemoptysis you have already told. And then we should see if patient got any signs of rash, purpras, and if he's getting any hematuria, getting any preorbital or periorbital or facial puffiness. So systemically, we should ask all the related questions to find out whether the patient got, or if there is any history of TB contact, history of weight loss, history of loss of appetite. So all these things will, that will direct us toward the right diagnosis.
Okay, thank you, sir. So there was no history of persistent rhinorrhea, epistaxis, nasal crusting, any bluish discoloration of fingers, and there was no history of any shortness of breath. In chest, there was only symptom of cough with hemoptysis. There was no pleuritic chest pain and wheeze. There was no frothy urine, no history of any numbness of hands or feet, and no oral ulcers, rashes, photosensitivity, and skin tightening, and no proximal muscle weakness symptoms were told. Patient was not diabetic or hypertensive. Past medical history was not remarkable for tuberculosis. Family history, there was no history of any autoimmune disease in this patient and no history of any asthma. Patient, although took shisha consumption, vape use, and cigarette smoking. I want to ask Dr. Shakaib here that this was a young gentleman, 23-year age, and nowadays IV substance abuse is being commonly taking place. So we have heard cases that sometimes these agents can also mimic vasculitis. They can cause nasal crusting and they can mimic ANCA-associated vasculitis. So please, sir, give your opinion on the drug history in these young cases.
Yeah, so shisha, I'm not sure about, but I've seen cases of cocaine-induced vasculitis. So cocaine along with levamisole can be pretty toxic.
Right, sir.
And it can cause a picture very similar to Wegener's GPA and stuff. The difference is that typically you can have both CNCA and PNCA positive. And you can have actually both MPO and PR3 positivity too. So, but obviously those patients have clear-cut reasons to have that kind of a clinical picture. Shisha, I'm not sure about actually.
Right, sir.
So it's not that popular where I work actually, so I don't know. Maybe the local data would be different.
Okay, so this patient was denying cocaine abuse and alcohol. In drug history, patient took NSAIDs and analgesics during this course. There was multiple courses of IV antibiotics. So I want to ask, we will go to the general physical examination. Patient was having normal blood pressure, respiratory rate was 24 per minute, pulse was 92. There was gum hypertrophy with a rash on the elbows which was maculopapular and non-blanchable rash which was likely a vasculitis. There was no jaundice, lymphadenopathy, cyanosis and clubbing. So what other systemic examination findings we can look in this context? Dr. Ali, please.
Hello. Thank you. I would like to check his chest and local examination of the nose and pedal edema, periorbital puffiness, as there is multi-system involvement, paranasal sinuses and respiratory tract as well. And you have told me that he is having the history of the hematuria as well. So related to kidney, I would like to extend my general physical examination to face and other signs and symptoms of the renal failure, especially ascites and pedal edema, especially.
Okay, sir. Thank
This
you.
gum hypertrophy, there is a condition called strawberry
Yes.
gums. Strawberry gums can happen with GPA, I think.
Right.
I think there are some malignancies which can do the same. So I think these two things will come to my mind.
Right, sir. So in the systemic examination, there were no crackles in the chest, no veins or bronchi, and there was no murmur. CNS examination was normal. There was no focal paresis, and planters were downgoing. Currently, at the moment, there was no active synovitis identified, although the patient was giving history of small joints and large joint pains. On the admission, TLC was raised 15,000, normal platelets, ALT, AST were normal. ESR was 94 with CRP 149 and procalcitonin was also raised. Creatinine was normal, Hep BC were negative. Urine DR, this was unremarkable and COVID test was negative. Sputum culture though came positive for MRSA. This is the X-ray of this patient. So here I want to ask a question from Dr. Ashraf Ali Khan, who is ID specialist. So this young gentleman has symptoms of likely autoimmune disease with vasculitis likely, and sputum culture is positive. So at the one end we have to treat the infections, and at the other end we have to treat the autoimmune component. So how could we balance these two different perspectives?
Assalamu alaikum, and thank you for inviting me to this conference and to this panel discussion. So, मेरा ख्याल ये है कि there may be two layers to this problem. इसको कोई underlying subacute या chronic illness भी चल रही है, something like an autoimmune disease. But on top of that, maybe he has MRSA pneumonia that can look like this actually. I mean, it may all be MRSA pneumonia. But I really struggle to think that, he wasn't given MRSA treatment. I mean, he must have gotten Targocid, he must have received linezolid and what have you. Because, if he went through multiple courses of antibiotics, he might have been given that. So that makes the situation even more complicated to think whether the MRSA is a colonizer on top of the GPA, or is it true infection? His PCT wasn't all that elevated. It was 1.1 to 0 point something at one point. So I may leave the MRSA alone, but I would also try to find out what was going on with him. Is he spiking fevers? Is it possible that because of all the IV infusions that he received, maybe he has MRSA endocarditis, and he's embolizing to the lungs from the right heart, endocarditis. That's a possibility. from infectious disease point of view. So I would definitely try and get him off antibiotics for 48 hours and repeat blood cultures and see if he grows that. And if the consideration is strong, such as if he has any murmurs, then I would also do an echocardiogram.
Okay. That's
TB testing?
Sorry?
TB testing was negative?
TB test later on was done, that was negative. Initially, when patient presented with hemoptysis, at that time COVID testing was done, and then later on TB test, that was negative.
Fungal testing?
Sorry?
Fungal cultures?
No, fungal cultures were not sent at that time.
Because these cavitary nodules bother me.
This is the HRCT test showing multiple cavities and non-cavitating nodules with CT PNS showing mastoid air cell opacification with destroying of bony septas. Patient ANA, DSTNA were negative, C3, C4 were normal, and ENA profile came out negative. Patient C-ANCA's levels were done. It was significantly raised, more than 200, and P-ANCA was negative. Our diagnosis is like granulomatosis with polyangiitis with ear and upper respiratory tract infection and chest involvement. Kidneys were spared along with MRSA infection. What other steps, management steps, like Dr. Ashraf Ali Khan Saab said that we have to treat the infection first, and after treating infection, we also have to look for the other sources like echocardiography for endocarditis. Then we can treat the autoimmune component. In keeping with high disease burden, concurrent infection ID specialists were consulted. Clindamycin was started in this case. Patient improved clinically. His CRP procalcitonin later on start getting normalized, and then low dose immunosuppression was started under cover of antibiotics. So methylprednisolone was given 125 mg per day with total dose of 1.5 gram, and first dose of rituximab injection was given 500 milligram. As he was also experiencing facial pain, pain management department was consulted, for which piroxicam, tapentadol and pregabalin were advised. He was discharged later on MMF and prednisolone with follow-up dose of second dose of rituximab after 1 week. Patient again admitted after 1 week in January 2024 with massive hemoptysis before the second dose of rituximab was due in this case, along with dyspnea and desaturation. In this time, patient was admitted to the ICU, and HRCT was showing multiple infiltrates in the chest, could be likely due to pulmonary hemorrhage. Injection methylprednisolone was started at that time with 1 gram per day dose for 5 days. IV immunoglobulins were discussed with the family, but they were not willing at the moment, as it is an expensive option in our setups. At the time they consented, after 5 days, patient clinically started getting improved and later on shifted to ward after stabilization. Prior to discharge, second dose of rituximab was planned, but pulmonologist suggested to defer the second dose, suspecting the chest infection, as raised TLC along with persistent cough and hemoptysis. After 1 week of this episode, patient again developed sudden massive hemoptysis and dyspnea, and at this time he could not make to the hospital and he died. I want to ask Dr. Shakaib that in this context, what gaps are there which are present in this case, and how can we modify the patient disease course during this time?
In my opinion, I think my suspicion for infection is pretty high compared to even the GPA presentation. So I think any attempt to get the biopsy of those lung nodules, whether it's, or maybe a bronchoscopy with bronchial washing, should have been obtained. I think he was relatively strongly immunocompromised too. I think he was given rituximab and then followed by Celcept also. I typically don't combine them together unless it's the last resort. In my opinion, I think TB or fungal infection, given the fact that they have cavitary nodules, And obviously an echocardiogram, as you mentioned, should have been done way earlier than later, because vasculitis picture the subacute bacterial endocarditis can also produce all the symptoms of vasculitis typically. Yes, ANCAs are strongly positive, and that's one thing. So, but I think clinical picture, in my opinion at least, there is a strong suspicion of infection.
Okay. For infection, but we often see that MRSA is often colonized in GPA cases in the nose, and in this case, culture came out positive. And there are case reports that sometimes it can flare up the disease in stable GPA patients. I want to ask Dr. Khalid that what is your experience in these cases? Should we do routine screening in these GPA cases to detect these colonizations? What should be done? Dr. Ashraf, please. Sorry.
Checking for colonization is not available everywhere. I think in the West they are doing MRSA PCR, for which the result comes back pretty quickly. But in an acute setting, if a patient is presenting like this, I don't know if I would do MRSA screening. I mean, it depends on the service. You know, if the rheumatology service does this as a routine, then yeah, I would favor that. If you find out that they are MRSA colonized, you could decolonize them with the use of mupirocin and with the use of chlorhexidine baths. Unfortunately, immunocompromised patients who are colonized with MRSA become recolonized again after decolonization. So I think it's something that we can try and then just screen them again to see if it's gone away. Other than that, you know, you would have to just treat the infection as it comes.
Okay. Thank you, sir. We have a drug approved. Sorry.
HRCT repeat. उसपे क्या findings थी?
There were multiple cavities and nodules in the HRCT chest.
No, repeat HRCT chest.
Sorry?
Repeat HRCT.
There were ground glass haze in the chest and along with alveolar shadowing. We were suspecting pulmonary hemorrhage as the HP dropped to about 2 units at that time and patient was desaturated. Though infection...
I think plex should have been done at this stage of the time. It would have benefited the patient in terms of infection control as well as ANCA-associated vasculitis presentation. Both of the things would have been covered with plex, plasmapheresis. If patient was not ready or patient attendants were not ready for the IVIGs.
Okay. But the current guidelines which we see, sir, there is more role of IV immunoglobulins told in these cases.
If patient attendants were not affording for the IVIGs, then plex should have been done at this stage of the time.
Okay, right. I want to ask another question from Dr. Mesam that in treating GPA cases, we see these patients have disease damage component as well as a disease activity component. So in managing these cases, how can we differentiate between these two aspects in this case? In generally, sorry.
What's the question again?
In GPA cases, these patients have active inflammation, active ongoing damage, and these patients often have past inflammation which has caused disease damage in this case, for which findings usually came on positive on repeated scans, and they are usually not responding to the immunosuppressant medications. So when a patient presents to us, so how can we differentiate between these two aspects, that the patient is having actually active disease at the moment, or the disease is in remission and the symptoms are due to the past damage?
For example,
For example, we see in SLE cases, nephritis cases, patient whose proteinuria is not getting settled after immunosuppressant medications. That is not getting normalized along with immunosuppressant medication updose. So
Obviously, if there is a proteinuria can stay there for some time, and with the treatment, it should improve. In case of SLE, for example, if we see we check for if there are any casts in the urine, for example, red cell cast or granular cast or anything like that. We also check the disease activity with the help of immunological markers like complements, anti-DS DNA testing. So we check the disease activity like that. Obviously,
yes, sir.
Actually, you want to ask what should have been done to check the disease activity? Is that the question?
Yes, often we see that C-ANCA level don't usually
Yes.
correlate with disease activity that well. So clinically, how other findings which we could see which could help us in this case?
ANCA levels gets higher when the disease activity gets higher.
Okay.
It is proportionately increases with the disease activity.
Okay, sir. Let's move to our second case.
One question I would like to ask
Yes.
for a comment from the panelist. That the same question I would ask as Umair has said, that this patient specifically had lowering ANCA levels while on treatment with mycophenolate, mofetil and steroids. But later on, with trends going down, the patient started having hemoptysis. So that also led to the important thing in mind that whether it was an infection or a disease burden. First, I would like you people to comment on that.
The
Second
question is that why the ANCAs went down?
ANCAs went down.
Yeah, I mean, like
but he was
ANCA's role is controversial, whether it goes up or down with the disease activity. It can be variable in a patient. So that's why it's not like included in the guideline that you always check ANCAs for the disease activity. So ANCAs in an individual patient can mean something, but it is not something that you rely upon. I think again, I think the question he was trying to get at was that how do you measure a disease activity in a patient when the changes are chronic or you always see them the same. I think it's a clinical condition which is important. For example, in this patient, as he was saying, if these cavitary nodules were like a month old and then you had a partial resolution or slight resolution, but the clinical condition was not improving, then you go with the inflammatory markers. Like has the SED rate improved, has the CRP improved, has the anemia improved, has the white cell count gone down. So you look at the whole clinical picture rather than one subset of, I think, part of the puzzle. I think, was the autopsy done and did you ever find the answer or no?
No, sir, autopsy was not done.
Secondly, just another part of it that this patient, when presented to us second time in December, end of the December, so he was also having a very overburdened infection. And with infection and infectious disease specialist input, she was of the idea that both needed the treatment. So Dr. Ashraf, with a low dose of pulse therapy, I think so, 125 milligram is also not a low pulse. It's a very high pulse, but we wanted to give the patient 1 gram.
Bronchoscopy with lavage or like any cultures to be obtained?
So cultures turned out to be MRCP.
No, with bronchoscopy, like
bronchoscopy wasn't
bronchial
done.
lavage or something?
It wasn't done. Pulmonology didn't go
That
for
would be
it.
the next step. Typically, pulmonologists would go with the next step if you're highly thinking about an infection, just to find out what kind of an organism. What do you, Ashraf bhai, don't you think like with cavitary nodules, fungus and TB would be pretty high on the list?
It becomes very complicated with the underlying possibility of GPA because, if he's having hemorrhages and that's more it's more consistent with some necrotic element to his disease, which is more likely to be the GPA itself. Having said that, TB also causes hemoptysis and necrosis. There are certain other necrotizing pneumonias, including MRSA, that causes necrotizing pneumonias, and hence the cavities and hence the pneumatoceles. So it's going to be really hard to decide, and we're going to have to rely heavily on the BAL, as Dr. Shakaib was saying, and or sputum cultures if they were available. Now, I understand that in a patient who's hemorrhaging, those studies are not, reliable or even available. So it's a tough one. I mean, you can look at the PCT and the rest of the clinical picture and try to figure out whether this patient is presenting with an infection or with a vasculitic process.
Actually, this
it's tough. I mean,
this patient's family was so much convinced that ANCA levels are going down, and so the disease is improving. So it was very difficult for us to convince them that it is other way around. And I think so they have denied plasmapheresis, IVIGs as well. So that was the turning point at that time that we missed this patient. Over to
if the MRSA grew during a previous culture, I wouldn't rely totally on treating the MRSA itself. The treatment should probably be broader than that and include community-acquired pneumonias and atypical pneumonias and such before we have any cultures available, if that. So I think something like linezolid plus piperacillin tazobactam would be the way to go. I mean, this patient could also have multi-drug resistant gram-negative organisms because of having been on multiple antibiotics. So treating him for those is a consideration, using newer antibiotics like Zavicefta or combination of Zavicefta and Estrionam. But that's a whole other chapter, you're opening up. But you have to rely on the cultures, basically.
Thank you, sir. Also, there are multiple studies coming on for finding new disease biomarkers in GPA, like IgG4 positive plasma cells ratio, which are there are multiple studies coming on. So let's see if there are any new marker come in the future. Now we are going to proceed to our second case. First. So this is a 31-year male, unemployed resident of Pakpatan, admitted via OPD on August 2023 with the complaints of worsening pain in multiple joints from past 6 months. Joint pain started about 3 years back involving small joints of hands, involving bilateral second and third MCPs, and large joints including bilateral shoulders and knee joints, along with swelling of left little finger and right middle finger, and whole finger was involved at that time, about 2 months back. Joint pains were gradual, additive, non-migratory, with early morning stiffness of more than 1 hour with function class 3, along with swelling and limited range of movements. It was associated with skin rash, which appeared about 1 year prior to joint symptoms, and there were silvery scales present on this rash. There was no history of any back pain, DIP joint pains, first CMC joint pains. There was no history of any visual changes, no symptoms of respiratory, GI, or genitourinary tract symptoms in this case. So there were no ulcers, malar or discoid rash, photosensitivity and alopecia, and no skin thickening. There was no history of any loose stools or blood containing stools, no IV drug abuse history. Patient was taking on and off analgesia and low dose steroid from past 2 to 3 years. Symptoms worsened about 6 months back, along with worsening of multiple joint pains. along with dactylitis. So consulted rheumatologist about 6 months back, for which tofacitinib was prescribed 5 milligram BD, but the patient was not responding to the tofacitinib. Past medical and surgical history was unremarkable. Family history, there was no psoriasis in family. There was no history of any smoking or alcohol in this patient. In drug history, patient was taking prednisolone 10 milligram per day along with methotrexate 15 milligram per week and tofacitinib 10 mg per day from past 6 months. Examination, patient was widely stable. An extensive rash present on the chest, shins, elbows, knee and scalp with psoriasis score 13.2, which was quite severe. Along with onycholysis and hyperkeratosis of nails, lymph nodes were not palpable and there was no jaundice, cyanosis or clubbing. This is the rash in this case. It has scales present on this rash. These are the pictures of the legs. On examination, wrists were swollen along with bilateral knees, along with dactylitis of left little and right middle finger. DEPSA score in this case was 44, which was showing high disease activity in this case. These are the pictures of the hands showing dactylitis with swelling of whole digit. Rest of the systemic examination was unremarkable. In labs, ESR was raised, CBC was normal, CRP was 24, creatinine and LFTs were normal, Hep C was B and C were negative. So the diagnosis is psoriatic arthritis. Patient tofacitinib was started and secukinumab was started with 150 milligrams subcutaneously every month along with methotrexate 20 mg per week. For analgesia, delta-cortil low dose was being given. Patient improved after 3 doses of secukinumab, injection Frizerone, and soon after patient again went into relapse with worsening of multiple joint pains along with worsening of skin disease. To date, 5 doses have been given and patient disease is not stable. So I want to ask Dr. Mesam that please tell what next management plan could be there to deal this case.
First of all, patient was started on tofacitinib and he hasn't responded. So the recommendations are to first try if patient is not responding to the disease modifying drug to start the biologics. And normally we start with the anti-TNF. However, if there is a skin involvement, we start with the IL-17. IL-17 is preferable because this is a plaque psoriasis and disease burden is quite high. The normal recommended dose is 300 milligrams of secukinumab. Right. So, my question is, what was the dose?
Patient was not given induction as patient was not affording. So, 150 milligram dose was given every month.
Okay. So, next step should be actually to increase the dose to 300 milligrams.
Right.
And if again there is no appropriate response, then we can always change the biologics to anti-TNF or IL-12 to 23 inhibitors.
As in the previous lecture, Dr. Ali told that there are studies which are being done on secukinumab without induction dose and with induction dose. Yes, the best should be to give the induction dose, but in those patients where induction is not being given, often studies show that disease response is coming late in these cases. Dr. Shakaib, I want to ask that if you want to add on this point, that how normally we should see the response after 3 months in these cases. Should we delay to check the response like we are 5 months have been done, and should we wait some time more in these cases?
I mean, like this is one of those cases I think where again I would have tested HIV too. That is a kind of a standard we check on everyone. The new onset psoriasis or a rapidly progressive psoriasis. So HIV should always be one of those things that you rule out before you embark on further immunosuppression. But I think Mesam was correct in that sense that obviously there is a delayed response expected, but I think the dose escalation like to 300 milligram, and I think he continued methotrexate or he stopped it?
Yes, he was taking methotrexate.
Sorry?
He was taking methotrexate.
He was given methotrexate. And I think there are also kind of those ideas about combining some low-grade kind of oral molecules such as, he could have had Tesla ka dusra naam kya? The one we were just talking about? Apremilast. So maybe a combination of Apremilast along with, if the dose escalation cannot be done due to unaffordability, maybe we can combine Apremilast, which I think in Pakistan is not that costly as compared to biologics.
Right.
So that would have been one of the maybe potential strategies along with the topical treatment that the dermatology can offer you.
Right.
I think it will probably take multi-medication care approach. And I don't think there is another IL-17, there's not another biologic in Pakistan, correct me if I'm wrong. I don't think we have IL-23s, right?
Yes. Currently IL-23 is not available. From Dr. Ali, I want to ask that in clinics, we often see this patient as this patient was having high disease activity. DEPSA was 44. And like the sir said that response to the secukinumab or any other biologics is not coming. But the disease is still high, disease activity is still high, but it has, in the response criteria, patient has shown active response like DEPSA has fallen down, but the disease is still active to some extent involving 1 to 2 joints. So what we should do in these cases further, generally speaking?
Actually, in this case scenario, we can increase the dose if patient is affording. 150 milligram once monthly, it was being given to the patient. It can be increased to 300 milligram once a month. If still he is not responding well to the treatment, then as very rightly said Sir Shakaib Saab, one should check for the HIV co-infection. If it turns out to be positive, then it should have been treated with ARTs. Then a patient would definitely be responding well to the treatment. But the lesions in this patient are very typical for the psoriasis. If they would have been like rashes, reddish or papillus squamous, then we should have gone for the biopsy of these skin lesions. So as we have seen variants of the papillus squamous variant of SLE rash as well. Yes, sir. So these two cases have already been discussed by Dr. Yasser. So I think we should go for the HIV. If not responding to 300 milligram once a month dose of secukinumab.
Okay. Thank you, sir. Thank you.
And second option is etanercept. That can be tried.
Okay. Thank you. That's a wonderful insight. So with this, I want to conclude this session, and I want to thank our panelists to be here and give their feedback on these cases. Thank you, sir.